Namaskar. Hello, everybody. I'm Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania. We will be talking about various Asian perspectives. So we have divided them into three groups. One group is Gulf countries. They may not be member of our CMAAO, but they represent the Asia. That will be spoken by Dr. Marthanda Pillai. And then we have the second group, which will be presented by our Singapore counterpart, Dr. Chong, on China, Taiwan, Singapore, Korea, Hong Kong perspective. Then we will have our Malaysian counterpart talking about Malaysia. They talk about Indonesia, Thailand, those groups. Then I will talk about the countries all around India. And we will try to find out, is there some similarity or not? And then if Russell comes, he will talk about New Zealand and Australia. So this is what we will try to. I will not be, if it is not possible to complete this meeting in one session, then we will continue this meeting in the next session, because we want to come out with some answers on this particular virus as a white paper. So I welcome Mari from JMA, Dr. Subramaniam, Professor Ashraf, Dr. Pillai. Rest will join, but I will start with Dr. Pillai. Dr. Marthanda Pillai is a past national president, Indian Medical Association, and he is a council member of World Medical Association. Can you have the next slide? Saurabh? Yes. Dr. Pillai, you can start. You have to unmute, Dr. Pillai.
A very good morning, Dr. KK. I'll briefly touch on what is happening in the Gulf countries. Although Gulf countries don't form part of CMAAO, whatever is happening there has an indirect bearing on Asian countries, particularly India, Pakistan, and Sri Lanka, and Bangladesh. A lot of our citizens are working in the Gulf countries, and it is also a source of income for the concerned countries also. And as for COVID-19, it has affected the Gulf countries also equally severely. And even at the right from the beginning itself, Iran was one of the first or second country to be affected, particularly from people who returned from Wuhan. And measures have been initiated even at that time itself. But Iran continues to be a hotspot still, and the number of persons getting involved are increasing. In spite of the lockdown and all, there was a relief, and when the number came down, relaxation of lockdown did happen, and this again has resulted in an increase in the number of patients there. Second comes, of course, Saudi Arabia. There again, the spread has been from Iran, a family which has returned from Iran. So way back in January and early February itself, the disease has been detected, and they have been very fast enough to start off corrective measures, including lockdown. As all of us well know, Saudi Arabia is a really a very holy place, and quite a lot of international pilgrimage is taking place in that country. And right from the beginning itself, they have Mecca and Medina, they have absolute restriction on visitors have been done there. And to that extent, the spread has been more or less controlled. And like other countries, there also the lockdown has been promulgated, and schools, educational institutions have been closed, religious places have been closed. Transport, public transport system is not in operation. Even public offices, except defense, health, and a few others, all the other offices are closed. And one good thing is there's a very good system of testing is being done. If you look at the number of person tested per million population, the number is really satisfactory as far as uh, Gulf countries are concerned, particularly Saudi Arabia and even Bahrain. This is being done. And another good thing is that no new visa are being issued now. And those who already have temporary visa or permanent visa, they are allowed to continue to stay there. And international travel obviously is not there at all, except chartered flights where people who are desirous of going back to their country of origin, arrangements are being done. And here again, the COVID test is being done, and whether they are positive or not is being checked. And to that extent, strict control definitely is there. If you take the Gulf countries all together, the total number of involved persons will come around 2.3 lakhs or in that range. And the cure rate is less than what we have in India. We have almost 62% or more of cure rate. There it is 50% or 40% cure rate is there. But mortality definitely is less, mostly less than 1%, except in Iraq, the percentage is around 3.2 or so. And another innovative thing is that the whole treatment is free in now the Gulf countries, particularly COVID treatment. It is free to all the citizens and expatriate, and that is a great relief to the COVID patients. And virtual OPs are being conducted, whereby e-prescriptions are being given, and to that extent, movement of COVID patients and others is restricted. Even non-COVID patients are restricted to a large extent, which has helped in controlling infection. So, if you look at the whole picture, Gulf country, the picture is satisfactory. Restrictions are in place, and appropriate areas emphasis is being given. Religious places, absolute restrictions are there. Visas are not being issued, and travel, international travel is almost completely not there except for chartered flights. So this is the picture as far as Gulf countries are concerned, and this definitely have an indirect bearing on the disease control in our country, because whenever the chartered flight come, out of the people who come, a good number unfortunately happens to be COVID positive. So back home, at least 28 days of quarantine, minimum of 14 is being imposed. So this is in short about the COVID issues in Gulf countries. Thank you, KK.
Any questions from all our colleagues? Can I take the share screen out? Today we have a working Elvin looking very smart. Yes, Dr. Nizami, you want to ask anything? On the Gulf issues, on the Gulf issues.
Thank you very much. I think, Mr. President, that presentation is well defined and very precisely. I just would like to extend my thanks for his work, what he has done over and explain to us about the girl. Thank you.
So the issue is that the mortality in the Europe is 7.07%. In US, it is reducing to 3.33%. And in Asian, it is 2.25% as a whole. All Asian countries as a whole, it is 2.25%. So there are two types of mortalities. A, we say case fatality. Second is infection fatality. So this data which we are talking about, 2.25%, 7.07%, 3.33%, are case fatality. Number of cases positive with RT-PCR and number of people died. So case fatality does not take into consideration deaths occurring who are corona-like illness. It does not include SARI. It does not include cases who died after 9 days because they may not be included as a COVID death. So case fatality, when we are comparing case fatality, there is another definition called infection fatality. How many people got infected and how many of them have got positive. Case fatality can only be detected by seroprevalence. So in that case, with the seroprevalence, the mortality should be less than 0.3% in Delhi, because if we take seroprevalence into consideration. So therefore, in US, they says 1/10. That means US also says multiply our number by 10. That will be the number of cases. That's the US definition. That means we have to reduce the USA by 10. That means again, there will also be a 0.33% case fatality, infection fatality. In Asian also, it should be 0.3%, 2.25 divided by 10.2%. Europe, it will be 0.7%. If we take that formula, that divide the case fatality divided by 10 is a rough estimate of infection fatality. Still, so because Dr. Chong hasn't come yet, I will take up the Asian part before that. So let me share some slides. So I'm trying to analyze the data of Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka, which is a South Asia region. So I'm trying to find out what is the difference between these 8 countries. The first of all, whenever we want to measure anything similarity, we need to find out population density. Population density is number of people living per square kilometer. That becomes very important because more the density, more will be number of cases in the first wave. The first wave will be much more in people with high population density. Our own study also shows if the density is more than 1000, number of cases are higher. And if the density is less than 200, number of cases will be lower. So if you see here, Bangladesh, 1,174 people, that is the Bangladesh density. Indian density is 415. Sri Lanka is 332. Pakistan is 274. Nepal is 201. If anybody has any other figures, I will change it right away because these are the data I have got it from the Google. These are not data I have not taken it from the respective national medical associations. These are the data on the public platform. Therefore, if I say except for Bangladesh, all our countries are between 200 to 400. So all our countries are 200 to 400 depending upon the density, but the density in Bangladesh is the highest. Now let's see total number of cases. This is global, we don't have to look at into it. Now we come back to in Southeast Asia. India has a total deaths per million population is 25. Pakistan is 27. Bangladesh is 18. Sri Lanka is 0.5. So if we see 18, 25, 27, they are not statistically significant. Nepal definitely is on the lower side. Maybe they haven't yet seen the peak. Number of cases are too low because that country is still not in its spread. So there are 3 countries who are showing a spread: India, Pakistan, and Bangladesh. All 3 of them, I would say between 20 to 25. So the deaths per million population is 20 to 25. That means nearing the same. Rest all will be a statistical cases with that. And if I see total cases per million population again, you will find 1147, 1249, 1409, almost statistically insignificant. So therefore, India, Pakistan, and Bangladesh are behaving the same. Daily new cases, we don't have to bother because that will depend upon the population. Number of deaths, we don't have to bother. Total cases also, I'm not. I'm only looking at 2 statistical analysis that India, Pakistan, and Bangladesh, they have the same genes, they have the same race, they have the same language, and they have a mixed population. They are behaving the same. Sri Lanka is behaving differently. Sri Lanka is behaving differently in spite of having the same density population, 332. So their density is the same. So therefore, we cannot say that Sri Lanka has reduced mortality because of they are maintaining, they are having a low density. No, density is the same, but the number of cases are very low and total deaths per million population is 0.5. Now let's see the case fatality versus infection fatality. So here we are talking about case fatality. Bangladesh is 1.28%, Sri Lanka is around 1%, India is 2.23%, Pakistan is 2.13%, Nepal is 0.25%. Again, we say Bangladesh, India, Pakistan are behaving the same. Indicators of health structure, that is per 1000 people, physicians, we see almost the same. So that cannot be the difference between Sri Lanka and others, because all of them are, I would say, 0 0.5, 0 0.7, 1, 0.91. So India and Sri Lanka have one physician per 1,000 population shouldn't make it. Hospital beds per 1,000 population, Sri Lanka has the highest. So that can be one reason that Sri Lanka infrastructure is better than others. That may be one reason of their reducing mortality. Now let's talk about preparedness. We say most of them as total expenditure 3.5, 2.9, 2.3, 5.6, 3.8. If total expenditure was the criteria, then Sri Lanka should not have been so better than India because percentage of GDP is the same. Out of pocket expenditure, 62, Sri Lanka is 49.8, 70. It doesn't differentiate me that out of pocket expenditure is responsible for the illness. Now, let us see what were the responses. Nepal, Sri Lanka had a first case on 27th January. So if you see Sri Lanka, India, they have similarly, the first case was nearly at the same time. 50 of more cases, India and Sri Lanka were on the same time. Country-wise lockdown implemented, Sri Lanka and India were on the same time. India, Sri Lanka lifted it on 28th of June. India lifted it much earlier. So maybe one reason is extended lockdown in Sri Lanka. That is the only factor we are trying to get. Nepal, the first case, Nepal is 1 month ahead of other countries. So therefore, Nepal can only be discussed from when we compare apple to apple. And when it comes to Pakistan, also the first came in 26th of February. So that means 1 month ahead of India. And Bangladesh on 8th of March. So Bangladesh, so even then, the only thing which is that Sri Lanka extended the lockdown much longer than other countries. Is that the factor? Now, if you go back to the positivity rate, Pakistan is 16%, Bangladesh is 19%, Nepal is 1.82% because Nepal has, so we can't compare Nepal because they have yet to show the peak, they have yet to show the spread. Sri Lanka is 3.48% and India is 11.6%. So India, Pakistan, Bangladesh, they all are more than 10% positivity rate. That means when the positivity rate is more than 10%, we say community transmission, practically community transmission. When it is less than 5%, we say lockdown should be lifted off. So these are the total tests. So I come back to, again, number of cases slide. Yes, total cases in India, if I see, in Bangladesh, it is 2.3 lakh. Sri Lanka is only 2,800 cases. Nepal is yet to show the rise. The rise will be there. Pakistan is 2,76,288. And India is 15,84,384, depending upon the population with that. Now, what do we infer with this? Let me come back to. So what changes, what are the lessons we are going to learn from Sri Lanka? Sri Lanka was the first one to eradicate malaria. Unfortunately, for the last 7-8 months, I'm trying Sri Lanka to come on board. I'm not been able to bring them on board. If any of you have a good terms with them, the medical association, we would like to listen to them. Because somehow or other, Sri Lanka was the first one to pick up malaria and eradicate malaria, which we have not been able to. So there is something in their country. When I say density, no, density is the same. So one criteria could have been the density. If density was the only criteria, then US and Europe, should have been a lower mortality rate than India. So it cannot be density. BCG vaccination, where we say India has a lower mortality because of a BCG vaccination. I really don't know how much population of Sri Lanka is BCG vaccinated. Hygienic index, yes. Hygienic index, Sri Lanka is slightly better hygienic, better infrastructure. AII rooms, which we will listen from other counterparts, India, Pakistan, and Bangladesh does not have enough AII room. If we can demonstrate that Sri Lanka has more AII rooms, that will be a game changer. Education, yes. Now, when I want to compare, this with, is Dr. Mathanda gone? So when we compare this data with the data of Kerala in India is showing the same pattern as that of Sri Lanka. So let me, before I go back, let me come back to Kerala model. So Kerala has only 23,000 cases and it has only 74 deaths. Only 74 deaths in Kerala. So 74, Kerala is 74 divided by 23614. So Kerala mortality is 0.3%. So the mortality in Kerala is 0.3%. The mortality in Sri Lanka is 0.3%. So is it, we are having two models in Southeast Asia. So my inference is that there are two types of models. One model is called as a Delhi-Mumbai model, where the seroprevalence, Delhi-Mumbai and Pakistan model, where the seroprevalence is 20 to 30%, and ultimately the disease gets controlled. And the second model is Kerala and Sri Lanka model, where the mortality is 0.3% because their seroprevalence is less than 10%. So there are only two ways of controlling this disease. Either you prevent it from getting it, that is Kerala and Sri Lanka model. You do not allow the disease to spread. Your public health measures are very, very, very strong. And the second is you let it happen. You let it happen, don't worry about it. That is a seroprevalence of when you 20 to 30% of the society gets the infection, then you get a control over the disease. So these are the observations from Southeast Asia, that you have two types of patterns we are seeing. One type of a pattern we are seeing where mortality is approximately 2%, infection mortality is 0.3%, and the two pattern, if you can prevent it, your mortality will be lower, and if you can, and your seroprevalence will be lower. So yesterday I was talking to Bangalore, they were saying their seroprevalence is approximately 10 to 12%. So if your seroprevalence is low, you are infecting the disease, and the day you make a mistake, you will have a surge in cases. Second is that you end up in infecting the population, densely population who cannot take the safety measures, who cannot prevent it. then the seroprevalence will be 20 to 30%. So I rest my case. Now I invite Dr. Chong to give his presentation on other countries with that.
Thank you, President. Sorry I joined you late. I was busy with some patients, just finished up. So is it possible for me to share screen?
Yes. Saurabh, can you?
Yes.
Okay. Okay, can you all, I just have a quick, just bring you all through a quick, thank you, President, for the opportunity to speak. Let me just bring you through some figures that I've just dug up over the last couple of days. So first we talk about China, and you can see that the number of cases is about 84,000, we know. Imported cases, quite a number, 2,396. But look at that figure below the confirmed cases. That's the last few days. The trend is going up, 34, 46, 61, 68, 101, 105, and 127. You know that after Wuhan, right, nothing happened to China until June the 11th, where they had an outbreak in Beijing. So these are the figures coming from not only Beijing, but now Dalian and the Xinjiang area. And what's going on is very interestingly enough, we talk about the Beijing outbreak. It was 256 cases from June 11th to 23rd. And prior to that, 55 days, they had no viruses. And again, it's a seafood market that triggered it, just like in Wuhan. So the Wuhan was a market. This one in Beijing was also a huge market. And apparently they say it's contaminated chopping blocks, boards in the market. And the salmon was from a nearby market that apparently somehow contaminated the chopping block boards. And the capacity is huge. They are testing people in the millions, but the outbreaks are in Dalian and Xinjiang in the last week. Again, Dalian is linked to a seafood company. So it seems like that kind of environment seems to have, allowed a spread. And they suspect it's from the contamination of the packaging rather than the fish itself. So, and you can see that the trend is going up, especially in the Xinjiang area. That is for China. For South Korea, it's pretty static, but the last 1 week, you can see the figures are also mounting. So all these are second waves or third waves. And the clusters are all over the place, from nightclubs, door-to-door sales, nursing homes, churches, and ports. So that's the situation in South Korea. In Singapore, I'm more familiar, so I've got a little bit more to tell you. We've got nearly 52,000 cases now. And you know, ours is a bimodal kind of situation. We have the community, 2,000 cases, and then we have the dormitories, 49,000. And in the figures in the dormitory continue to be huge, continue to be 3 figures. And you can see the community figures are less than 5. You see the second figure, 5, 2, 1, 3, 4, 3. These are the figures in the last few days. Now, why is this so? It's because actually we're trying to now clear the dormitories. I'll come to that in the next slide.
Your slides are not shifting. Your slide is the static, the first slide.
Yeah.
Oh, is it?
Not moving.
Can you see now?
No, it's the same slide.
Only first slide.
Oh. Okay, then I tell you what. Maybe I have to play the slide. Is that better?
No, still the same slide.
Sharing is paused.
Can you close the slides and restart again?
Okay. Yes. Sorry, let me do this again. Can you all see the slides?
Yes.
Yes.
You can see the slides. Okay, I'll start all over again. Sorry about that. Okay, so China basically, they have been very well after the Wuhan situation has been, resolved. But in the last, since June of the 11th, they have had outbreaks in Beijing. And in the last week, they've had outbreaks now in Dalian, which is to the north. a city to the north, and in Xinjiang, which is far out there in towards the Central Asia. And what happened is that in the Beijing outbreak, it was traced to a market in Beijing, and they had 256 cases between June 11 and 23rd. And this market is much larger than the Wuhan market where it started in Wuhan. So this market is about 22 times bigger. And they found the virus on contaminated chopping boards. And the salmon was implicated, and it wasn't the fish, it probably came from imported salmon and the packaging of the salmon. The salmon actually came from a nearby market about 10 kilometers away. And so they have more or less controlled the outbreak. But in the last week, they've had outbreaks in Dalian, and again, it's linked to another seafood company, just like in Wuhan, just like in Beijing. So it looks like these seafood, when you handle imported seafood, that cold, dry environment somehow allows the virus to, to be preserved, and then when you thaw everything out, the virus is infectious. So in Xinjiang and in Dalian, you can see the number of cases. I'll go back to the previous slide. They are going up: 34, 46, 61, 68, and so on, and 127 yesterday. So they are having some issues. Now in South Korea, again, the number of cases are rising in the last 1 week. You can see the figures: 113 yesterday, and
Can you change the next one? Next slide.
Next slide. Can you see the next slide?
No, it's still China.
Oh, can you see the slide now?
It's still China.
Okay. Can you see it?
No.
Okay.
What is happening?
It says resume share, but
Saurabh?
Yes.
We'll have to do one by one.
okay. Can you all see this now? South Korea?
No, nothing is seen.
Your screen is white.
Can you see this?
No.
Okay.
I think what you need to do is you need to close your presentation and restart. The presentation is getting hanged.
Oh, is it? Okay. Let me do that again. So sorry. My apologies.
Yeah, we can see the South Korea slide.
You can see it now?
Yeah.
Yes, South Korea, yes.
Okay. Can you see it now? Can you see the South Korea slide?
Yes, yes, we can.
Okay, great. So South Korea is basically, you can see the number of cases are rising as well. And it's 113 in yesterday, and previously was 58, 25, and so on. And the clusters seem to be centered around nightclubs, door-to-door sales, nursing homes, churches, and ports. All right. Now I'll go to the next slide. Can you see the Singapore slide?
Yes.
Okay, great. Okay, so Singapore's, I can tell you a little bit more about what's happening in Singapore. I'm more familiar, and the situation is that we've got a kind of like a bimodal situation here. We have the community cases, which is only 2,000, and we have the dormitories, which is 49,000. So the dormitories are segregated from the rest of the population because the dormitories are sort of like segregated. So you can see that the dormitory cases are 400 something in the last 1 week, from 300 something to 400 something. But the community cases are only 5, 2, 1, 3, 4, and 3. And I'll explain to you later on what's going on there. Now, our ministry has just released the figures just of yesterday, how many people were admitted to ICU. So we had 128 people admitted to ICU since February. And we had 0 in ICU for the last 2 weeks. And the deceased is 27. So our ICU cases breakdown is 98 are discharged. 8 of them are still in general ward now, 18 deaths from COVID, 4 deaths from other cases. All right. And the number of tests performed, you can see for yourself, is now 1.32 million. Now, the dormitory situation is, can you all see this slide?
Yes.
Okay, the dormitory situation is that we have 320,000 workers in 43 purpose-built dorms and 1,200 factory dorms. These are dormitories where if your floor of your factory is empty, you just put your staff there. So now what we're trying to do is we have cleared or recovered 262,000 people. What do you mean by recovered? Well, 50,000 of them have recovered, and we are now trying to clear them of the virus. That means we're swabbing everyone. So our target is to finish swabbing everybody by 7th of August. We have cleared 900 over factory dormitories. And in the 17 purpose-built dorms, we have cleared 64 blocks. So what we do is we go in en masse and swab everybody in the dormitories. And if we find any cases, we pull them out. We come back 1 week later, we swab them again. And we find any cases, we pull them out. And if they're all clear, we come back, we swab them twice to make sure they're clear, and then they are all discharged, meaning they can go back to work. So that's why we have a large number of dormitory cases every day. Is actually from the swabbing exercises going on. And our swabbing is something like 13,000 a day, or even more now. So that's what's happening in Singapore, China, and South Korea. Thank you very much, President.
Thank you, Dr. Chong, for a wonderful presentation. Can I take the sharing off? So we don't have the presentation from other areas. So I want to come back to some consensus. Mary, you want to talk about the Japan model? Okay, let me come back that density is not the criteria for difference in the level of infections in the community. So we have seen density is not the only criteria. So density is not the only criteria, because Sri Lanka density and India density is the same. Other countries, Singapore and Hong Kong, the density will be different. Now, health index, will it make a difference in the mortality? That if your country is more hygienic? The answer is, if so, then European should have been not having a higher mortality. So it is not dependent on your hygienic status of the society. AII room, I still am working on it, that availability of airborne isolation rooms, does it reduce mortality? Maybe one, because there we need to confirm that in other parts of the country, as we are getting a lower mortality in China, Taiwan, South Korea, they have AI, Hong Kong, they have AII room. Does education makes a difference? Yes. But if education was the only factor, then Europe should not have got such a high mortality, because they all are educated people. So if we say that in Kerala and in Sri Lanka, the mortality is low because they have a higher education, doesn't look like. Infrastructure should not make a difference, because the ICU now is required only by 1%. The mortality will change not more than 0.15%, because that will be the change in mortality between a good care and a not a good care. Religious movements, I think, is one of a major criteria because Iran proves that wherever there are religious movements and not maintaining a social distancing, you can end up into an infection. Government treatments, yes, it may also make a difference because specifically in uh, countries where you dictate the government treatment, the mortality may be higher because professional autonomy is gone. You are decided by the government or you're decided by the insurance company. Seafood market is another thing which has come wherever there are frozen markets. Can the virus be more in those particular areas? And then we also need to find out nightclubs and nightlife. Whichever areas there are nightclubs and nightlifes, do we find experts? So there cannot be one single answer. So there will be somewhere it will be density, somewhere it will be health index, somewhere it will be presence or absence of AII room, somewhere it will be education of the people, infrastructure, religious movements, government treatment or a private treatment allowed, then frozen markets and the presence of nightclubs, nightlife, because at that time you have heavy use of alcohol. And after alcohol, you forget about what physical distancing is because you will not remember that you need to have a physical distancing. So these are some of the parameters I have got. And two things we have observed is there are two models, prevent it or get it. If you can prevent it, as long as you can prevent it, the disease will not come. You do a mistake and there will be a surge. China, Taiwan, Singapore, Hong Kong, all I've seen, whenever you do a mistake, any of the mistake mentioned earlier, some of your areas will show a surge or let it happen, which we have seen in New York, we have seen in Iran, we have seen in Italy, we have seen in Delhi, Mumbai, we have seen it in Ahmedabad. Now we are seeing it in Bangalore. So either you say, let it happen, let 20% of the society get infected. We saw that in Italy, and that exactly happened. The seroprevalence is 20%. Open for discussion.
Yeah, Mr. President, can I present something from Hong Kong?
Yes.
Yes, please.
So I have some time to do the clinical work the past week. And in fact, in Hong Kong, the third wave is quite serious. In fact, up to June, end of June, we only have 1,200 confirmed cases and 8 died from COVID-19 only. And then the maximum number of confirmed cases in the second wave in April is only 65. Yet in the third wave in July, we saw hell. And what happened? I think the origin of the third wave is from the entry of some seafarers, seamen, and the air crew. They were exempted from the routine testing of COVID-19 and the quarantine procedures because it is for their, for the benefit. They said that they need to just change the crew in Hong Kong to have the connecting flights. And so they had applied to the government for exemption from these tests. And that is the big loophole. And then it is coupled with the relaxation of the rules of the social gathering, limitation of meals in the public areas in mid-June. And so the people got relaxed, and also the fatigue in the in all the quarantining and the social distancing measures for COVID-19. And then when these contaminated seamen entered Hong Kong, visiting, touring around, they infected the taxi drivers, and they infected all those tourist spots, and then shared the virus with the Hong Kong people, unfortunately. So that is a big loophole. And in fact, so the fact is now we had already 3,271 cases, much more than the local residents of Singaporeans. And we had already 27 mortality cases, you know, and now it's the same with Singaporean, but you have none in the ICU right now. So I would see that your 27 statistics figure would be stable, unchanged for a month perhaps, but probably we will have more than 30 or even 40 next in August. So I was so very upset by the loopholes and the strategies made by the government that had opened up the third wave. And in fact, we don't have that capacity to have en masse testing in Hong Kong. We have the bottleneck of testing. So we only can test right now, it's only 13,000 a case per day. And we had started some screening for those high-risk groups, that is the taxi drivers, the people working and visiting and staying in the elderly home. We had also routinely tested those people in the markets, supermarkets selling things. And also we had also tested the people in the very populated areas with a lot of infected confirmed cases. And also the people working in the restaurants, the caterers, we also tested for them. And for these people, we had tested for the past few days only about 40,000 people. And out of these 40,000, we had screened 16 confirmed positive cases. And most of these are asymptomatic or very mild cases. And so the government had some contingency plans for this uprising. So first of all, we had invited the mainland laboratory people to come to Hong Kong to help us to have some en masse screening, like in Singapore, I think. So Singapore is very good that you had more than 1 million citizens tested already. I guess you had produced or manufactured your own testing kits. But in Hong Kong, we don't have them. So we have to now import the help from mainland China. And so the government had now plugged the loophole, and they don't allow any exemption of testing and quarantine measures that allow those stopover air crew or seafarers. But I guess that's too little too late. There are still some exempted groups, I understand, of course, those government officials or very important commercial people traveling between Hong Kong and China, etc. and etc. So we think ultimately these loopholes should be plugged. Anyway, so for the manpower, we still have adequate manpower in a way. We have 6,290 doctors working in the public hospitals and the hospital authority. And in fact, only half of the public hospital beds were occupied in the past 2 months because to cope with the COVID-19 emergency, we had stopped all the elective surgeries, all those elective cases in the public hospitals. Of course, that sacrificed the health needs of those people needing to have their cancer, to have their tumors resected, etc. And the coronary arteries procedures. I think that is not satisfactory, but the manpower had to be pooled to deal with the COVID-19 emergencies. And so, by the way, one team of our scholars in the Poly University had found out that, in fact, we found the D614G gene mutation in a cluster of seamen entering the sailors entering Hong Kong from Kazakhstan and Philippines. And these DNA expression is the same as many clusters of people infected in Hong Kong in the third wave. And so, I think we all had to be very careful about this. And with this gene mutation, we found that the patients in the third wave became much more serious than those patients in the second wave. They were more infectious and the conditions were more serious. So, and in Hong Kong, in the virology department of the University of Hong Kong, Professor Yun had been also working on the research to produce vaccines against COVID-19, but of course it's much slower than those in Oxford or in mainland China. They were already in the third clinical stage in Brazil for the Chinese team. But in Hong Kong, we are still in the second team. So in the coming winter, we are, well, crossing our fingers whether we could have enough vaccines that could be used in our community, that we could import these vaccines from Europe or from mainland China. In the past, our experience is that they only gave us the leftover because the European markets and the American markets are so big. And for the Chinese companies, of course, they are producing their own. But then, well, in China, you have 1.4 billion people. How much they could provide Hong Kong people, I don't know. So I don't know what are your plannings in other countries. I think prevention by vaccination is still the most important thing, planning for the future. And I think that's all I have to share with you right now. Well, of course, in Hong Kong, we also are importing the help from mainland China to help us to construct some makeshift square cabin mobile hospitals for those asymptomatic patients and the less serious young patients, say in the modified Asian World Expo, the exhibition center, which were not used for the past few months because no exhibitions will be held in Hong Kong after all. So, and we also had modified some resorts and holiday villages in Hong Kong to cater for the quarantine purpose, to hope that the cross-infection in Hong Kong from those mild cases or serious cases won't be exaggerated in the future. But because in the past month, in the third wave, we found it very unfortunate that some patients confirmed to be COVID-19, yet they had to stay home for a while for home treatment or quarantine. And that made the cross-infection to their family members affect. In the past, we worried about this, but now it had become a fact. So we had sped up the reconstruction of those village centers, resort areas, villages to become quarantine centers. Besides, in the past, some people have to pay to stay in the hotel for those family quarantine or close contact people. But they don't want to pay, then they have to stay at home. So that it makes the trouble. And now the government had reconstructed these villages, hopefully, that we can entertain all those quarantine requirements. Thank you very much.
Thank you, Elvin. Because the time is already up, we will continue this discussion because we still have to hear other countries. We still have to hear about the Thailand, Indonesia, Myanmar, and Malaysia. So I'm only going to say at this particular moment 2 points. Postpone, postpone, and postpone as long as you can. We postponed in India thinking summer will kill it. And summer came and the virus never got killed. So our hypothesis was wrong. And so you can postpone this infection as long as you can. And now people are postponing in the hope of a vaccine. That vaccine will come. Let us postpone this disease in our country, close our international borders, close national borders, do not allow foreigners to come, become like an extended prison with a hope that the vaccine will come. And if that vaccine also fails, then the only answer will be that 60% of the society of the whole world over a period of time will get infected. And our aim should be on reducing mortality as much as possible. Unfortunately, all the funding is towards vaccine. the research on treatment is not that much. That much efforts are not going on how to reduce the mortality. Every effort, every country effort is vaccine, vaccine, and vaccine. So let's see. In India, we have both the models. We have a Kerala model, prevented, prevented, prevented. We will not allow it to happen till we do a mistake. And we also have a Delhi Bombay model. 20 to 30% people have already got infected. And we say that we are safe. The number of cases in Delhi are static, absolutely. For the last 15 days, number of cases are in a plateau. They are not reducing, they are not increasing. So these are the two models. We'll continue our discussion next time. We will continue our discussion next time because we have not yet been able to find out the answer. At this moment, it looks like is prevented as much as you can, waiting, but compromising travel, postponing meetings, canceling all your meetings. I don't know what the situation is going to be, or face it. Face
Mr.
it.
President, just a few lines, if you allow
Yes,
me.
please, please.
Thank you very much. Hence, I was been given the task about the Iran to speak about Iran, what has happened over there, and hence we are running short of time. So I'll be just.
We are continuing this. We are continuing this next time.
No. I'll just be brief because already you have compared all that. So I think, which is matter of my concern as CMAAO, I mean the member, that is in Iran, the medical staff has been infected more than 10,000 and medical staff deaths are about more than 126. And same is true for Pakistan and India and so on. So I think it is not as to be acceptable to us as health professionals and as association, and as we have to speak about it. And secondly, just I wanted to share with you about the Sri Lanka model and Kerala model. I think religion has nothing to do with it. The main thing that is the get together, or I mean this jumble people, they don't follow the directions or SOPs, that is the safe distancing or the social distancing, that is one of the nature over there. And literacy plays a very great role in prevention of the disease. And certainly the culture over there, the Sri Lankan culture and the culture in Kerala. Here in Pakistan, I mean, I don't speak about Sri Lanka. Thank you very much to President that he has informed me, and I have learned about the Sri Lankan model too. But I used to speak in Pakistan media about the success story of Kerala. And I believe that is the system, the health system, and moreover, the system of the governance over there that plays a very vital role in the prevention, the treatment, and the behavior to address the disease overall in the society and the health system too. Just and brief, and certainly if the next time we will be
I
speaking.
agree. I agree. Next time we will continue other countries. I just want to correct. I did not say religion. I said religious gatherings. We may be irrespective of any religion. So I said religious gatherings. I said
Mr.
religious gathering irrespective of any religion,
Yeah,
if they are not maintaining physical distancing, because Korean outbreak was from that. Korean outbreak was in a church. So if you are not maintaining a Iran, yes, initially all the people were in the religious gatherings. That's for physical distancing is not being followed. So origin may have been there. So therefore, we need to have a SOPs for all religious meetings, whether it is irrespective of the religion. I agree because we need to study more. We will discuss. We'll start next time with Professor Ashraf Nizami, talking about Iran more, and whatever we have spoken, more extension to that. And then we will have Malaysian counterpart talking about Malaysia, Indonesia, Myanmar, Thailand, because those also have a lower mortality. Dubai is totally open as on today. So let's continue our discussion before we make out any. When I say conclusion means till now I've only been able to understand that you cannot prevent it, because China now saying resurgence, Hong Kong is saying we are getting it again. So, Singapore is saying we are getting it again. If every country says we are getting it again with the smallest mistake, then we are all hoping against hope, or hoping only for the vaccine. If the vaccine fails, then we will be back to square one. That's what I'm trying to say, because it is not dependent on density alone. It is not dependent on education alone. Everywhere you will make mistakes. So if it has to happen, if it had to happen, it's okay. Delhi, Pakistan has shown, Delhi has shown, Mumbai has shown. Let it happen. The mortality is not that high. Thank you. We'll meet next time.
Okay. All the best. All the best. Thank you very much.